And at the outset, again, I'd like to welcome you all for the Neuroscience Forum. The Neuroscience Forum, coordinated by Dr. Rajesh Babu sir, is one of the most well-attended meeting of IMA Coimbatore, and I am happy to say that this is we already got 200 attendees, and we have got two star speakers today. Dr. Professor Balakrishnan sir, who is also my senior in college and from PSG Institute of Medical Sciences, and Balamurali sir, who is also an authority in the field of neurosurgery from Chennai Apollo Hospital. Welcome all the speakers, and I wish the program a very good success. Thank you all.
Thank you, Kaushal Ram.
Good evening, everyone. I welcome you all for this Neurosciences Forum meeting, which is being conducted along with the Indian Medical Association Academy of Medical Specialties Coimbatore branch. This month we are going to have the two speakers. One is Dr. Balakrishnan, another is Dr. Balamurali. Both are going to give an exhaustive lectures. The only thing I wanted to tell you is that those who are not become the member of the Indian Medical Association, please join in the Indian Medical Association. And also, I invite and request you, all of you, to become member of the PPL scheme, which is the scheme which is helpful for you people. If you get any litigations, it will be your protection. That is what. So, term insurance is different, but this, even if you are alive till the age of 85 years, 90 years also, it is valid. We need to pay only for 25 years for the family security scheme. So, I request all of you, those who are not members of the Indian Medical Association, throughout Tamil Nadu, whichever place you are, you please join in the Indian Medical Association and become a member and a member of the schemes also. Because this is the only forum which protects doctors all along in our country. So, we will straight away go to the first topic. Update on the management of the acute ischemic stroke. Professor Balakrishnan is HOD of the Department of the Neurology in the PSG Institute of Medical Sciences and Research, Coimbatore. General Medicine from Coimbatore Medical College and DM Neurology from Madurai Medical College. And DNB Neurology and MRCP Neurology UK, Royal College of Physicians UK, and FEBN, European Board of Neurology, and he has worked as an assistant professor in the PSG Institute of Medical Sciences, and now he has become the HOD of the Department of the Neurology. Next. Next slide. He had research publications of 50 plus peer-reviewed publications in leading national and international neurological journals. International Journal of Stroke, European Stroke Journal, Applied Soft Computing Journal, and Journal of Stroke Medicine, and Annals of the Indian Academy of the Neurology. Academic and professional activities. He is the examiner in the MCH Neurology for the Madurai Medical College, and DM Neurology for the Jubilee MC, and DM Neurology Calicut MC, and DM Neurology CMC Vellore. The conference chair and faculty, assessment of the tremors Neuro Update Chennai, transcranial Doppler Shine 2019 Chennai, nerve USG in 2019, faculty Burcha, Shine 2021. He has a membership in Indian Academy of Neurology, American Academy of Neurology, Indian Stroke Association, International Headache Society, and Movement Disorder Society of India. He has got a book contribution, Case Studies in the Cerebrovascular Diseases in the Ishwaradas Kalidas Ramasamy book. And awareness program, he is conducting various awareness programs on stroke, TIA, epilepsy, migraine, peripheral neuropathy in the PSG IMR, and a research study co-investigation for the extract TV25 study. So I invite Dr. Balakrishnan sir to give his talk on update on management of the acute ischemic stroke.
Thank you, sir. Thank you. Um, can you see the slide, sir?
Yes, sir. See.
So, good evening, everybody. This is a very interesting and maybe the most need of our topic. Can you see the slides and can you hear my voice?
Sir, it is clear, sir. You can go ahead.
Yes, sir. Yes, sir. So I think because all of us see the stroke patients, and I think the my talk content of the topic is going to be, I think we should recognize the stroke as early as possible, and we should image the patients as early as possible, and we should give them a thrombolytic therapy if the patient is in the window period and eligible. And the next one is if the patient has a major vessel occlusion, like large vessel occlusion, I think then we should advise them to undergo a mechanical thrombectomy. So I'll just go through one by one. So we all know that it's a medical emergency, and we have two mnemonics to remember the stroke whenever we see these patients. One is fast, that is facial drooping, then arm weakness, slurring of speech, and it's time to call maybe 911. But India, I think we can call 108. And one more mnemonic is be fast, that is balance issues, eyesight issues, and face drooping, arm weakness, and speech difficulty. And then time to call this 108. I think stroke is like an acute meningitis or RTA. This has to be, it's a medical emergency that has to be considered as a medical emergency. But many times we see these patients are coming very late, like after maybe 6 hours or even after 1 or 2 days to our OPD or emergency, thinking that it will recover on its own. So we have to be very we have to educate the patients and the society to recognize the symptoms of stroke and reach for the medical help as soon as possible. So we all know that there should not be delay in diagnosis and treatment, and we have to any patient with acute stroke, urgent diagnostic assessment has to be differentiated, and sometimes it may be a stroke mimic like hypoglycemia, or maybe a subdural hematoma, or maybe a small tumor in the brain. So why this has to be considered as the fourth leading cause of death and the fifth leading cause of disability. And this global disease burden of disease study highlights that stroke was accountable for around 6.6 million deaths, around 1.143 million disability adjusted life years. But one more important thing is that India is going to face around 51% hike in stroke cases in the over next 30 years. This is a study from the Lancet. So we all know that stroke is characterized by a focal neurological deficit attributed to the focal injury to the central nervous system by a vascular cause. So including cerebral infarction, intracerebral hemorrhage, subarachnoid hemorrhage, and cerebral venous sinus thrombosis. This is the first one. I think we can see there is a small infarct on the right side, and this is a MRI diffusion weighted images showing there is an infarct in the left frontal lobe. And we all know this is the most common site for any interstitial hemorrhage. This is basal ganglia, which is extending into the thalamus and into the ventricles. And this is a classical subarachnoid hemorrhage, typically blood in the basal cisterns. And this last one is a typical cerebral venous sinus thrombosis. We have clots in the superior sagittal sinus and the transverse sinus. So it's all considered stroke. So CVT is considered as a venous stroke. So this is the classification of stroke subtypes. We have one major stroke classification called stroke toast classification. But here I am just mainly the instances around 85% of all strokes are ischemic. So only 15% are hemorrhagic, and most common cause is like small vessel ischemic disease like lack of
Matt.
Next one is atherosclerotic cerebrovascular disease, and cardioembolism comprises of around 20%. Even though with all this extensive investigation, sometimes we may not be able to identify the etiology in around 30% of people. That is called cryptogenic stroke. And other 5%, I think we can see this cocaine, amphetamines, and or some hyperhomocysteemia, and other APLA, so they can cause around 5% of the strokes. So whenever we see a stroke patient, we always evaluate the cause for the ischemic stroke. That is very, very important. Because if the patient is having an antiphospholipid antibody syndrome which is causing the stroke, the treatment is totally different. So we have to give a lifelong oral anticoagulation. If the cause for stroke is in the paroxysmal AF, so we have to give anticoagulation for lifelong. So if the patient has a dissection, so we have to give anticoagulation. So whether we have to give only antiplatelets or we have to give anticoagulation, and how long to give an anticoagulation, like whether if it is a dissection we give only for 6 months. So if it is an phospholipid antibody syndrome or cardioembolic, we are going to give lifelong anticoagulation therapy. So if it's a small vessel lacunar disease, we are going to give only aspirin. So there is a atherosclerotic cerebrovascular disease like IC occlusion, sometimes we may need to do a carotid stenting. So this is the treatment is decided on based on the what is the specific etiology. And this is the updated definition of the stroke in 21st century. So the CNS definition of CNS infarction is the infarction in the brain, spinal cord or retinal cell death attributed to ischemia based on the pathological imaging and other objective evidence of cerebral, spinal cord or retinal focal ischemia defined as a vascular origin. So and evidence of this kind of focal ischemic injury and symptoms lasting for more than 24 hours or until death, and we have to exclude all other causes. So definition of ischemic stroke: episode of neurological dysfunction caused by focal cerebral. So sometimes spinal cord infarction is also called stroke, and sometimes retinal infarction is also called stroke because they have tried thrombolysis for spinal cord infarctions or retinal artery occlusions also. There are instances. So if you recognize the spinal cord infarction within 4.5 hours, sometimes it's very difficult to recognize the spinal cord infarction, but there are instances in India itself that have been thrombolysis for spinal cord infarctions and retinal infarctions. And sometimes we see a silent CNS infarction in the MRI. So this is the imaging neuropathological evidence of CNS infarction without a history of acute neurological dysfunction attributable to the lesion. Sometimes patients say they never had any stroke. But if you see a MRI, there will be a large infarct in the MRI. Sometimes they may have had only a small vertigo or some numbness. They thought it is something else and they are not consulted a doctor. So this silent infarction is one of the major causes for cognitive dysfunction and gait difficulties in the later part of the life. So not only we should concentrate on the brain, we should consider the spinal cord and the retina also. Sometimes AAON or central retinal artery occlusion also come with sudden loss of vision. So this is a central retinal artery occlusion having a cherry red spot. The retina is very pale. So this is typically of a central retinal artery occlusion, and there is a evidence of disc edema. So and this is a spinal cord infarction typically in the dorsal cord. This is typically an artery of Adam-Quist infarction. So we have a lot of conditions which can cause a spinal cord infarction also. So risk factors, all of us know that I think the obesity, the stress, I think all of us are prone for maybe the stroke, and the patient having underlying heart disease or diabetes and hypertension, dyslipidemia, alcohol and physical inactivity, and sometimes some medications also can cause like hormone pills and smoking. So we all know what is the risk factors for stroke is like as a cardiologist for acute myocardial infarction. And this is a typical picture of MRI showing typical, this is a typical M2 infarctions, and this is anterochoroidal artery, this is superior cerebral artery, this is anterior inferior cerebral artery, this is posterior inferior cerebral artery, this is the pontine stroke and the middle cerebral peduncle stroke, this is also pontine stroke. These are typical lacunar strokes, and this is typical PCA stroke, and this is typical MCA, then this is MCA, and this is lenticulostriate branch typically involving the basal ganglia, that is M1. So whenever we see as acute stroke, we always look for what is the reason for the stroke, and always we look what is the arterial territory involved, because when deciding the stenting, so we should know so which is the vessel, culprit vessel which is causing the stroke, so specific etiology and which is the vessel is involved. So how to evaluate a patient with ischemic stroke when they come to us in the maybe emergency or in the OPD. So identification, sometimes the acute hypoglycemia can have a hemiparesis or even aphasia. So we have seen patients coming to the emergency as like acute stroke, but actually they have a hypoglycemia. We just treat the hypoglycemia, they become all right. And usually when the patient has a seizures, they can have a posterior torus palsy, which can also cause a one-sided weakness, but MRI is going to be normal. And sometimes they come with one-sided weakness, there will be a tumor. So we have to make an exact diagnosis before we just proceed next. And pre-hospital treatment, I think we don't have like in ambulance with the CT scan availability, because in many places outside India, even KMSH, they have a ventilator, CT scan with ambulance. So if you have a suspected stroke, we are able to assess like a sugar and other basic investigations. And the CT is normal, we can even do a thrombolysis even before patient reaching the hospital. So then the next thing is whether the patient can the baby thrombolysis can be tried this acute stroke, ischemic stroke patients, and mechanical thrombectomy can be done if the patient is maybe indicated. And post-stroke rehabilitation and carotid and vertebral artery stenting for symptomatic vessel occlusions. So that is called secondary prevention. So you have to make a correct diagnosis and identify patients for eligible patients for thrombolysis and mechanical thrombectomy, and in-hospital treatment like antiplatelets and statins and other heparins, and rehabilitation like physiotherapy, speech therapy and swallowing therapy, and stenting to prevent the secondary strokes. So the recent AHI guidelines in acute stroke management, they have recommended that we have to do the basic imaging within 24 hours of patient reaching the hospital. So at least the non-contrast CT branch should be done within first 25 minutes to rule out an interstitial hemorrhage. And if there is no interstitial hemorrhage, NIHS more than 4 or 5, so we can definitely thrombolyze the patient in the CT console itself. Many times we do the thrombolysis in the CT console, then we shift the patient for an MRI. So we have to have a multidisciplinary stroke teams must be activated. Like in our hospital, we have a code stroke. It's been activated whenever the patient comes to the emergency with suspected stroke. This may not be stroke, but suspected stroke, we have this stroke alert. So we all the people like neurologists, neurosurgeons, anesthetists, radiologists, and so everybody will come to know that there is an acute stroke. So there is any emergency, patient has to be taken for surgery, or a patient has to be intubated, difficult intubation. I think we all available. So then we have to assess whether the patient is a large vessel occlusion like terminal ICA or distal M1, proximal M1 or basilar artery occlusions. So then we have to do a CT angiogram. So as soon as the patient comes to the emergency, we have to do a CT scan brain to rule out ICH. If there is no large ICH, NIH is more than 4 or 5, you just go ahead with thrombolysis. And then if we suspect a major artery occlusion, then we can do a CT angiogram next. So emergency brain scan, non-contrast CT and MRI has been recommended. So effective non-contrast CT is very good for reduction of acute ICH, even though MRI is also detects ICH, but CT is the ideal investigation. So in a study like the first study which conducted using RTPA, they have used only a CT scan and then do a IV lysis in most patients. And if the patient is coming like wake up stroke, patient went to the sleep normally, but when they woke up in the morning, they are having weakness, we don't know the exact onset of time, then we can do definitely in a CT perfusion or MR perfusion, or we can do thrombolysis based on the MR diffusion weighted and flash mismatch. We have done many patients with this kind of mismatch and we have done a thrombolysis. So there is a diffusion weighted changes, but flare there is no change. So then the patient has a typical penumbra, so we can do a thrombolysis. So in the suspected patient with acute ischemic stroke and large vessel occlusion within 24 hours, so we can do a mechanical thrombectomy up to 24 hours. We can do thrombolysis up to 4.5 hours, but we can do a thrombolysis even up to 24 hours based on the criteria like CT perfusion or MR perfusion or diffusion flare mismatch. We in our hospital done thrombolysis up to 9 hours in one patient. So presence based on the MRI findings. So, patient who are eligible for mechanical thrombectomy, they should have a CT angiogram from aortic arch to the skull vertex. Look for any IC occlusion or MC occlusions or basilar occlusions. These are the three vessels. If they are not opening up after the thrombolysis, so then we will take up the patients for mechanical thrombectomy. So within 6 to 24 hours, so we can process like this mismatch and all, we can just process. So as soon as the patient comes, we have to do a CT, and if the patient is eligible, we have to do a thrombolysis. Then we can do a CT angiogram, or even MR angiogram is sufficient. If MR angiogram is not showing any large vessel occlusions, LVO, then there is no role for any mechanical thrombectomy. If the MRI is not available, just do a CT scan brain. You just thrombolyze, then ask the patients to undergo a CT angiogram. If the CT angiogram is not showing any large vessel occlusion, then it's only medical management. So we all know that there is a thrombolysis. We can use Tenecteplase or a Tenecteplase. Now Tenecteplase has been overtaken the Tenecteplase, and in our hospital we always use Tenecteplase because there are a lot of advantages, single bolus and easy to use, and dose calculation is very easy. So Tenecteplase infusion has to be given over a period of 1 hour. So the first thrombolytic approved for stroke thrombolysis is Tenecteplase, and the first thrombolytic agent tried in acute stroke is a streptokinase. The study was stopped early because there is high incidence of interstitial hemorrhage. Because we all follow the cardiologist, because cardiologists use streptokinase for acute MI thrombolysis, we also tried streptokinase, but the study was a failure, and then the Tenecteplase came in 1995. Then Tenecteplase was shown beneficial within first 3 hours. Then they have extended the window period up to 4.5 hours. And now the Tenecteplase has taken over the thrombolytic agent of choice. So why we have to worry about the acute stroke? See, whenever there is an arterial occlusion, there is an area of infarct which is not going to be reversed. Then we have area of a penumbra, which is a risk of irreversible damage. So our target is to prevent the loss of penumbra, and oligemia is also there. This is a mild blood loss. So this black area is not, we will not be able to do anything even if we do a thrombolysis or thrombectomy. So what we are aiming is at the area of at risk, that is the penumbra. To salvage the penumbra, we have to do a reperfusion strategy as early as possible. The reperfusion of the vessel is done by either thrombolysis or mechanical thrombectomy. So impact of acute ischemic stroke treatment, like thrombolytic treatment. So every 100 patients treated with the RTPA, so 32 patients are going to have a better outcome. So 13 patients are become normal or near normal. So the incidence of interstitial hemorrhage is only 6%, and 3 become worse and worse outcome and dead. So the number needed to treat is only 3. So compared to the aspirin, which is the beneficial effect is only 77. So number needed to treat is only 3 for acute ischemic stroke thrombolysis. So we should thrombolyze the patients if they are eligible, and if they come to us within 4.5 hours. So this is a MINS recommendation for emergency medicine response team. So door to needle time, so meaning as soon as the patient comes, we should finish all the investigation, and we should thrombolyze within 60 minutes. So which we always call like in cardiology also. So door to admission, the aiming is around 3 hours. So we should aim like this if possible. So this is a golden time. I think initial assessment should take only 10 minutes, and stroke team notification, CT scan less than 25 minutes, and interpretation of the labs and the CT scans within maybe 45 minutes, and within 60 minutes we should do thrombolysis. But pre-hospital lysis is not possible in our country because we need a CT scan with an ambulance. So for thrombolysis, I think we need to have a definite deficit. So age more than 18 years, and now they are even thrombolizing pediatric patients. And CT brain, we have to have exclude ICH and mimics. As I told you, hypoglycemia, posterior tarsus palsy, SOL brain, SDH, and tumors, And sometimes hemiplegic migraine and functional weakness also can come with a one-sided weakness. So we have to be very careful in excluding the stroke mimics. So then absolute exclusion criteria, if there is a interstitial hemorrhage or subarachnoid hemorrhage, more than one-third of MCI territory, we should not do a thrombolysis. BP is more than 185, 110, we should not do thrombolysis. Any ischemic stroke within last 3 months, we should not do. Any severe head trauma within last 3 months, active internal bleeding, aortic dissection, we should not do. Arterial puncture in non-compressible sites within last 7 days, we should not do. Infected endocarditis, GI bleeding within last 21 days, or structural GI malignancy, or spinal surgery within last 3 months. Then we have a exclusion criteria like INR more than 1.7, platelet less than 50,000, or PT more than 15, or APTT more than 40, and sugar less than 50. And in the presence of the patient has given low molecular weight heparin within the last 24 hours, I think we should not thrombolyze. And receive direct oral anticoagulation like abixapan, dabigatran, rivaroxaban, we always should try to reverse it and then before do a thrombolysis. So IV thrombolysis, Tenecteplase shift. Now this come the latest recommendation is class 1 recommendation. So the new one, the previous class 1 recommendation is Alteplase. So maximum dose is 90 mg, 0.9 mg per kg. So 10% bolus, other 90% as 1 hour infusion. So Tenecteplase is 0.25 mg per kg, single bolus, maximum dose is 25 mg. So we can just push like an IV fluid. It's very easy. So the dose is also very clear. I think 60 kg, I think is volume of administered 3 ml. So we know exactly how much dose has to be administered. So after thrombolysis, we should not give aspirin or any heparin for first 24 hours, and we should admit them to intensive stroke care or stroke care unit for monitoring. And if the patient develops acute headache or acute hypertension, nausea, vomiting, or worsening of neurological deficit, I think we should take a urgent CT scan brain to rule out interstitial hemorrhage. And we should monitor BP every 15 minutes after intravenous thrombolysis for 2 hours, then every 30 minutes for 6 hours, then hourly for 24 hours. So we should frequency of BP measurements if systolic BP is more than 180 or diastolic is more than 105, and administer antihypertensive medication to be maintained at or below these levels. And usually we do a Ryle's tube insertion, catheter insertion before the patient was maybe going for a thrombolysis, because after thrombolysis if you put a nasogastric tube they can have a bleeding. So usually we do a follow-up CT scan or MRI scan after 24 hours before starting antiplatelets and anticoagulation. So pediatrics has been, there is instance of pediatric patients getting thrombolyzed or even pregnancy patients getting thrombolyzed. So this all maybe decided on a case-to-case basis. So I am going to give some examples of stroke thrombolysis which is successful. This is 58 male, acute onset left hemiplegia. Within 3.15 hours patient has come, and you see this is the right side, there is a right side hyperdense middle cerebral artery territory, sign, and MRI showing this the M1 lenticular striate occlusion including some temporal lobe infarcts. The patient was sliced within 16 mg Tenecteplase in the emergency, and this is the initial MRI. You see this M1 is completely cut off in the right side. So this is the post-lysis. Then always we just check with an angiogram, either CT angiogram or DSA. So but there is an M1 occlusion, we always take up the patient for DSA, look for any residual thrombus, or if the clot is maybe vessel is not opened, we always do a mechanical thrombectomy. So this patient had luckily, I think this M1 is fully opened up. So this patient had a very good recovery in the follow-up. So this is the follow-up CT showing there is some hemorrhagic transformation in this thing, and this usually resolves over a period of 1 or 2 weeks. So there is no new infarcts, and the patient had a very good recovery in the follow-up. And this is very interesting patient, 61 male, hypertension, polycythemia, and he had a vertigo and ataxia at 8 a.m. reached hospital by 9:15, and GCS was low, 9/15, electrically intubated in the emergency before imaging. So this is a CT, and you can see the hyperdense basal artery sign. The basal artery is very hyperdense, And this MRI showing this right cerebellum plus this spontaneous infarct, and the MRA showing the basilar artery is completely occluded in the proximal part. So this patient was thrombolized at 10:30 a.m. with around 18 milligrams of Tenecteplase. And this is the post-lysis DSA showing complete recanalization of the basilar artery. So I am shown that two cases are, and one is basilar artery, one is MCA. This is not always the cases in all the patients. Sometimes vessel is not opened after the thrombolysis, then we have to go for a mechanical thrombectomy. Sometimes mechanical thrombectomy also, the lysis usually improves 60% of stroke patients. So another 30 to 40% they may not improve with the thrombolysis. Even thrombectomy also, the thrombectomy usually 30% of patients with basilar artery occlusion or MC occlusions. See, we may not be able to do remove the clot in around 30%. So that's failed mechanical thrombectomy. So as I told you, so whenever there is a major occlusions like ICA, proximal MCA like M1 or M2, basilar occlusions, I think we have to do a mechanical thrombectomy. So this is the indication. I think acute anticirculation ischemic stroke, proximal intracranial large artery occlusions, ICA or M1. So in NIHS more than 6 or 6 to 24 hours period, wake up strokes. So then we have to do a MR perfusion diffusion weighted imaging to decide for mechanical thrombectomy. So mechanical thrombectomy can be done up to 24 hours of stroke onset, and if there is a large vessel occlusion like ICA or M1 or basilar artery. So this is the rapid arterial occlusion evaluation. If the patient has this kind of positive more than 5 plus, I think this indicates there is a large vessel occlusion. Mainly the patient has a aphasia or agnosia, or a patient has a gaze deviation, then the patient has definitely a large vessel occlusion. So mechanical thrombectomy, there is a strong indication do a thrombolysis and strong benefits. It definitely improves the MRS
சரியாச்சு வந்துட்டானே
90 days.
இன்னும் நீ 5 நிமிஷம்
And endovascular thrombectomy can be done in aspects of 6 to 10. So this is a terminal ICA and a proximal M1. So we can do a mechanical thrombectomy even up to 24 hours. This is one of our patient who had a M1 occlusion. Just see this failed thrombolysis, and this is following mechanical thrombectomy. This is completely opened up the vessel. So this patient also had a very good recovery. So we can do even up to 24 hours also if there is a good aspects and perfusion mismatch. So just remember, thrombolysis is up to only 4.5 hours, or some cases we can do even up to maybe 9 hours, even up to 24 hours. But mechanical thrombectomy can be done up to 24 hours if the criteria are met and the patients are willing. So there is a good aspects, we can just do thrombolytic maybe mechanical thrombectomy up to 24 hours. And these are the studies shown the beneficial effect of mechanical thrombectomy up to 24 hours. This is one of our patient, right hemiplegia and aphasia. You see there is a right M1 occlusion, and this is an angiogram showing this is a M2 vessel occlusion here. So here you see a clot here, and you see this distal branches. This inferior division is also thrombosed in this patient. So this is following a mechanical thrombectomy. You see the vessels are fully opened up. You see the superior division and inferior division is completely opened up following a mechanical thrombectomy. So as I told you, the mechanical thrombectomy will not be able to will around 30% of patients. And post-circulation stroke also, the vertebral artery or basilar artery occlusions may be considered for thrombectomy within 24 hours. The benefit is up to 24 hours, limited data more than 80 years. So there is a basilar occlusions. there is a class 1 recommendation for doing a mechanical thrombectomy. So blood pressure management, I think we should have reduce the blood pressure below 185/100. So first 24 hours BP has to be maintained around less than 180 and 105 first 24 hours following a thrombolysis. So then we have to have a good glucose control also. The target is around 140 to 80, and we should not, usually we don't use FT fibrotide and thyroid following a thrombolysis, but some patients following mechanical thrombectomy, we have used thyroid because the vessels are getting recurrently occluded, and we should not use a dianyl for reducing the cerebral edema. So we should avoid hypotension and hypovolemia, and to maintain a good perfusion, and we have to manage the concomitant events like so in the patient with acute ischemic stroke, early treatment of hypertension is indicated only required by a comorbid condition like heart failure, aortic dissection, post-thrombolysis SAH, pre-eclampsia and eclampsia. So in hospital supportive care, and always we should screen all the patients with acute stroke to look for any evidence of neurogenic dysphagia, because many a time the patient develops aspiration pneumonia, and the patient always needs for ILST for some time, like 1 or 2 weeks. But sometimes post-circulation stroke like lateral malar syndrome, they may require ILST for like months. And anticoagulation, if there is an atrial fibrillation, or if there is a thrombus in the aortic arch, or if there is a thrombus in the carotids. And always we have to look for a screen for depression in all stroke patients. So this is the last few slides. Sorry for that. So we have to create a stroke awareness to the society to recognize the patients with acute ischemic stroke or any acute stroke in all age groups. So thereby we can decrease the disability of the stroke patients. And mobile stroke units to improve the onset of treatment and outcomes, and telemedicine where the neurologists are not available to improve the identification of the acute stroke treatment. So in the emergency department, timely assessment of suspected stroke in adults and children. So stroke code activation and transfer protocols. And emergency brain evaluation is the key to evaluate ischemic burden. Then early imaging, then thrombolysis has to be done, and it has to be managed by a stroke multidisciplinary team. And if the patient is not improving with thrombolysis, then we have to go for a mechanical thrombectomy. And continue quality improvement, stroke severity documentation, data registry participation. So we have to maintain a good registry and registry management for maybe study purposes. And this is a stroke prevention. The last one is stroke prevention, and we have to have a good diabetes and obesity control, dietary modification, BP targets, and BP control, lipid lowering, and then antiplatelet therapy. Normally we use aspirin and clopidogrel for at least 3 months. Some studies shows us only 3 weeks, then followed by single antiplatelets. So there is a ticagrelor indications also. When there is a failure of clopidogrel, we can use a ticagrelor also. So there is no evidence for anti-inflammatory drugs in the primary prevention of stroke. So here, so what I want to stress is, so whenever you see a patient with a stroke, so always we have to recognize a stroke, rule out stroke mimics, and do an emergency CT scan brain, and identify patients who are eligible for stroke thrombolysis and mechanical thrombectomy. And so stroke thrombolysis can be done in any peripheral hospital with maybe good like looking at the inclusion criteria, exclusion criteria, and absolute contraindications with BP control. So we can do thrombolysis even the peripheral centers. So mechanical thrombectomy can done, whereas the procedure can be done available. So I just want to stress the primary prevention is also very important, and we have to recognize a stroke early, and all the patients should get an eligible treatment. And then, so if you use proper treatment and do a thrombolysis mechanical thrombectomy, and the long term outcome is going to be very good. We have had patients basilar occlusions going home within week, and coming with coma and completely recovered, M1 occlusion, left M1 occlusion, global aphasia, right hemiplegia, going home completely normal walking, normal speech. So I think I just want you to understand that whenever you see a patient, you should try to do a thrombolysis, and if the patient is eligible for thrombectomy, I think you can do yourself. You can refer to which hospital, which is the nearest hospital, and so that they can have a very good outcome. Thank you. Sir.
Thank you, Dr. Balakrishnan sir.
Yes, sir.
Dr.G Balamurali sir,
Thank you.
who has done a MRCS from Edinburgh and MD from UK and FRCS from neurosurgery. He is the director of the Kauvery Spine Institute, Kauvery Hospital, Alvarpet, and managing director, Hamsa Rehabilitation, and director of Get Fit 360 Weight Loss and Wellness Program, and adjunct professor, Sri Balaji Medical College, Chennai. Internationally trained spinal neurosurgeon with 30 years experience, 16 years in UK, trained in UK, USA, Germany, and Switzerland. Expertise in minimally invasive and complex spine surgery, spinal cord tumors, trauma, and pediatric spine. Academics and research degree, MD, University of Cambridge, UK, 65 plus publications, 10 book chapters, 300 plus presentations, conducted multiple courses and workshops, awards and recognition, awarded by Dr. APJ Abdul Kalam, contribution to the spinal cord injury care, Dr. Award from Tamil Nadu government, listed among a top 50 most influential people of Chennai 2020, recognized as top spine surgeon of South India 23, 24, and 25. I invited Dr. Balamurali sir to give his talk.
My topic is going to be something to happen after a stroke, and the importance and advances in neuro rehabilitation. What are the opportunities? Spine and neurosurgeon. I head the Kauvery Spine Institute at Alvarpet, Chennai, and I'm also the managing director of a chain of rehabilitation centers in Chennai, Bangalore, Vellore, and Trichy. So with that, the disease pattern has been changing over the years from the 1990s, where respiratory infections, ischemic heart disease, diarrheal disease were the predominant. Now the commonest problem is ischemic heart disease still leads number one, followed by road accidents, which leads to spinal cord injury and brain injury, followed by cerebrovascular accidents, which causes stroke, which we heard very beautifully how Dr. Balakrishnan had spoke previously. So, falls are usually from the commonest cause of head and spine injury, causing brain as well as head. And India is number one with the largest population in the world. And being number one, you can imagine the burden of spinal cord injury and brain injury on our healthcare system. We also are the largest contributors of diabetes, hypertension, stroke, obesity, and various other lifestyle related disease. And with an urbanization, our lifestyle and food habits, I think we are seeing more and more strokes at a very young age as well. Heart attack again will lead, and people who have either an angioplasty or bypass surgery, they also need some form of rehabilitation in terms of lifestyle change and controlling their blood pressure and all the comorbidities that are related to that. We are the third commonest cause of death, as highlighted the significance of stroke and early management of stroke, which is not always accessible in the rural parts, but in the urban, we can get to a hospital. Thrombolysis is very important to prevent stroke. But even if you prevent a stroke, and if you treat a patient, about 55% of people do suffer from disability, and sometimes this disability is lifelong. We are also living longer. We are in more nuclear families and we don't have much people to take care of us. And there's a whole load of problems coming with living longer, with knee replacements, back problems, falls, dementia, Parkinson's. All of these things lead to some form of disability. And we're also forgetting a huge load of children with significant problems, rising incidence of cerebral palsy, autism, learning disability, ADHD, and so many other things which are being recognized more because of the urbanized lifestyle, because parents do not have much time to spend with children. There's a lot of speech related problems as well. And this again needs rehabilitation. So rehabilitation is one very big area that is being neglected in our healthcare. So if you look at the way the global-DALY is the disability adjusted life year. HIV, AIDS, and diarrheal diseases have reduced significantly, but diabetes is on the rise. Alzheimer's is doubled and dementia has doubled, and stroke and road accidents increased by 210 million years of years lived with disability compared to 2019, in the last 20 years. So we are living longer. So our life expectancy has increased by 6 years. Our healthy life expectancy has reduced. That's because we are living longer, but living with more disability. And also the requirement internationally is also significantly high, and 85% of our population live in the developing countries, do not have any access to rehabilitation. That's because the proportion of importance that healthcare gives to rehabilitation, you will realize that, for every one doctor, there's 1,000 specialists of rehab doctors who are coming. So I think this itself shows that, we are not prepared to deal with problems after a major injury, illness, stroke, brain injury, spinal cord injury. Whereas we are very good at acute care, and our healthcare system is geared more for acute care than for chronic care. And the biggest challenge is because of affordability and reimbursement for rehab. Currently, insurance companies do not reimburse for rehabilitation. So why rehabilitation? After any insult, there's neuronal damage, there's complete or incomplete deficits, there's a lifelong disability that needs to be taken care of. And we have to avoid complication because these people are going to live. People with the spinal cord injury usually happens in people less than 40 years of age, mostly men, mostly breadwinners of the family, and they are going to all live a normal life like anybody else up to 70 or 80. And they're going to get old with disability, and they have to live with complications and avoid these complications throughout life. So the debate is, how early do you mobilize? When do you send them to a rehab center? The reason for my talk, which I mentioned to Dr. Rajesh Babu, is that a lot of us here are general physicians or general doctors, and we see either patients or family members or somebody we know who has an a disability. We do not actually take efforts to send them to a rehabilitation or suggest them. Our commonest thing that we do is, okay, so, admit them at home, send them home, get a physiotherapist to manage. But that is not the right way to do. With all due respect to physiotherapists, they are the only one part of the team member. So how can you start sending? When do you send patients? Most studies say that patients should go from acute setup immediately to the rehabilitation center. So as early as possible. People with spinal cord injury, findings suggest that statistically efficacy significantly reduces in acute care and the total length of stay, and highly significant reduction in the incidence of bed sores, chest infections, UTI, and so many other problems are sent immediately from day one. Complications like DVT, PE, pneumonia, MI, sepsis, and various other complications can be reduced if patients are mobilized early. So we tend to mobilize patients after any spinal injury. We make them sit immediately, and if they are incomplete, we put them on a caliper. We start mobilizing them as soon as possible. So really, it's very important to understand that the outcome is significantly better in patients who go for rehabilitation and those who don't go for rehabilitation. So we can mobilize them as early as 3 to 6 weeks when the patient is medically fit. So rehabilitation really involves a huge multidisciplinary team of rehab doctors, nurses, physiotherapists, occupational therapists, speech and language pathologists, psychologists, dietitian, vocational neurologist, neurosurgeon, spine surgeon, plastic surgeon for bed sores, for bladder bowel incontinence and problems. You have urologist, a general surgeon. People are severely depressed, so you need a psychiatrist and a pediatrician in children and other problems. So conventional rehabilitation is what is being followed everywhere, where it involves a physiotherapist with some basic equipments for functional training, for mobility, for standing, for sitting control, wheelchair training, and various other things. So that I think most of you are kind of aware of. But today, with this given time, I thought I will talk to you about what is the future. Where are we heading towards in terms of advancement? And that is mainly because of the advancement in technology. Like any part of healthcare, whether it is surgical field or medical field, technology plays a major role. So if you look at bedsore, is the commonest cause of death in people with spinal cord injury, especially if they're neglected and they're not, they don't know how to manage that. And the normal thing is you have a air mattress and you do bed turning every 4 hourly, and sometimes even just a 2 hourly turning is good enough. But now we have a lot of very advanced technology where we have beds which control the pressure source. So you have beds that will tell you when to turn a patient. It will show the proportion of pressure. So these are mattresses which are with various sensors, and these are all AI device as well to them, able to bed. Power irrigation systems. You can actually
புரியுங்க
pull
கேக்குதா?
body stroke, they do control over the
புரியுங்க கேக்கலையா?
field area,
புரியுங்க கேக்கலையா?
different things that are available of neuromodel. So neuration means is spinal stimulation, intraspinal pumps, and various surgeries that done like dorsal rhizotomy, selective rhizotomy for pain management, because sick with a stroke have some form of pain, and it's very difficult to manage their pain. This can be usually a visceral pain, it can be a so you can have a baclofen pump that helps with spasticity as well as dealing with their pain. Then you have bladder stimulators. So this is available in India, and many surgeries are being performed in India, where people who have a neurogenic bladder, you can have a kind of a pacemaker that is fitted in your body, which will identify the pressures of the detrusors and the muscle and the bladder muscles, and these pressures are converted to signals, and you can actually empty the bladder. Baclofen pump, as I said, is used for spasticity. It's kept very percutaneously. There's a small pump that is attached in the abdomen and the tube that feeds in regular baclofen. And this is very useful, and it can be very useful for people with severe spasticity from stroke or brain injury or spinal cord injury. And also can be used very focally in the hands. You can do Botox injections as well, but baclofen pumps are very useful. Then you can do surgical procedures like, selective rhizotomy, where you just cut a small group of nerves which produce the pain and spasticity. And again, it's a very well-known surgical technique where you use a neuromonitoring during your procedure, and you can try and perform this. Now, the future is from conventional, we moved on to computer-based and biofeedback. There's a lot of systems that are available, which are biofeedback systems, which are EMG-based or EEG-based. And these EMG and EEG-based systems are very, very useful, and to identify and trigger the system, and they trigger patient movement, trigger muscle contracture. And so this is the basis of many systems to robot and other things. So the technology is advancing very far from what we have been used to in terms of virtual reality, wearable technology, gamification, because rehabilitation can be very boring, both for adults as well as children. So a lot of technology now has gone in terms of gamification, and we also use tele-rehabilitation. So gamification is essentially, it's all motion sensors like your Nintendo or your Sony Xbox kind of systems, where you can actually try to do these things through various games. And then you have the functional electrical stimulation, where you can use EMG motivated, EMG triggered systems, which will help you with your activity and motion. And these can be connected to prosthesis, because the functional systems electrical stimulation actually stimulates muscle groups. And so these are attached to various equipments and instruments. We can also have various control devices. For example, people are quadriplegic, or if a right-handed person cannot use a computer, so how they can trigger environment control, how they can open doors, how they can work on a laptop, how they can drive a car. So many adaptability devices are there, and these are helping people with mobility. So freehand systems, where you can have specific implants which give stimulation to the hand in brachial plexus injury or strokes. And these are again combined with EEG and EMG stimulation. Then you have neural prostheses for people who have amputations. So you can fit in these prostheses which are controlled with either neural pathways from the brain, or through functional electrical stimulation. Then you have the brain computer interface. This is a technology that is coming up, and trials are in the phase. And in fact, in India, we have the first trial with ISRO, based in Trivandrum, where we are able to directly bypass the spinal cord. These are in patients with spinal cord injury, where you can actually control your body function, or you can control a prosthesis with just your memory. So your brain signals are converted to EEG, and EEG signals are converted to electrical signals, picked up, and then it can produce a function. Then we also have now a spinal cord stimulator, which we have done a couple of trials in Kauvery Hospital in Chennai, where we can place in electrodes in the spinal cord, and these give stimulation to the lower limb. And you need to select the patients, and usually they work better for lower thoracic from T8, T10 below into the lumbar, and you can stimulate the spinal cord to produce function. This has to be combined with about 3 to 6 months of rehabilitation, and it will work. We can also use other, deep brain stimulators and various other stimulators for pain and motion. Then you have the transcranial magnetic stimulation. So you have magnets that are placed in the brain, and this can be used for depression, Parkinson's, for stroke, and various other treatments. You can use transcranial magnetic stimulation, and this will create new neural networks. It will improve the neuroplasticity, and neural plasticity is the basis of a lot of these activities. And adaptability devices you can have, which is basically come from the military in the US. Like you have seen in the movie Avatar, you can wear certain devices and you can walk. And this is also being now, manufactured in India. And these are called exoskeletal systems. They are motor generated, they are EMG triggered, and there are various other systems, very advanced. They are expensive, but they are proved to be very useful. Uh, Wheelchairs are modified in so many ways. You have sitting wheelchair, you have voice control wheelchair, and for a person who cannot use his hands to use the wheelchair, so these can be activated through voice, can be activated through blowing air by touch. You also have automated stair climbers. You can access, few steps or many steps. You can have vehicle modifications, where people who have incomplete neurological deficits can still drive with adjustments in their seat and wheelchair. Robotic rehabilitation is making a big revolution, and we are able to come up with a lot of robotics for upper limb, for lower limb, for gait training, and various other activities. And again, the idea here is neuroplasticity. The more you use your muscles, you either use it or you lose it. So if you don't use a group of muscle, then you're going to lose those muscles. And to retrain them, sometimes you need repetitive movements, repetitive activities, repetitive functions. And that is why robotics is becoming very popular. There's plenty of research. And in fact, there are many centers who now have robotics in India for rehabilitation. And I also like to mention that about stem cell therapy. We think that stem cell therapy is an advancement, and India is probably India and China are the countries where maximum stem cell treatments are given. But unfortunately, this is actually illegal and it is banned in India. So there is no evidence until now that stem cell therapy has any benefits in human spinal cord injury. Though there is plenty of research going on for the last 10, 20 years, at the moment, there isn't much benefit. So the future holds a good promise, but right now it is illegal. And do not encourage your patients to do them because they charge a lot of money, but there's no much benefit seen. So teamwork, end of the day, is it's a teamwork, and it is a combination of either the surgeon or the physician who sees these patients, the therapist, and the technology with the patient in the middle. So I thank you all for listening. There are plenty of rehabilitation centers that are coming up around you. So identify rehabilitation centers in your center. Hamsa Spine and Brain Rehab has been there for, and I just want to show you that we have centers in Chennai, and we have a team of physiotherapists, occupational therapists, speech therapists, psychologists, peer counselors, and so many other people who are providing this therapy. It's very intensive. Some patients stay for 3 months, sometimes even up to 6 months, because that is the kind of time that they require for being able to do rehabilitation. Children also require rehabilitation, and it significantly improves their outcome. And early intervention is very important. The sooner the child comes for a rehabilitation, the better they improve. And for the children's rehab in most of our centers, we have all gamified things. We have robotics. We have many systems that are required to improve their adaptability and so that they follow them regularly. So I think the future of neurosurgery, stroke for the neurophysicians is that they really need a rehabilitation setup where patients will benefit from the outcomes. And I kindly recommend the awareness needs to come from the doctors first before the patients. I think doctors should identify most cities, most metros, most towns have small centers. NGOs do a lot of work on rehabilitation. And identify centers and please refer your patients to them because that is the only hope that they have after a major injury. And if they are not there, we see a lot of patients come with bed sores, UTI, chest infection, MI, complications related to that, spasticity, pain, fractures from osteoporosis, because they are not aware of the importance of rehabilitation. So I thank Dr. Rajesh Babu and the IME for giving me this opportunity. Thank you so much.
Thank you, Dr. Balamurali sir, for your exhaustive lecture. Till we have 187 people are there in the meeting and attending the program. It was a very nice session. And actually for this meeting, around 345 people registered for the meeting actually. And it was a very nice session. Thank you for all the participants. And I thank both the speakers, Dr. Balakrishnan and Dr. Balamurali, for giving a very nice lectures.